have some tests to see whether both the primary hemostasia and the secondary hemostasia are working properly. Okay, some of them are in vivo and others are in vitro. Okay, the first one that we are going to see is to check whether it is working okay, the primary hemostasia. This is called the bleeding time. The bleeding time is to see whether our primary hemostasia, remember that where the small clot that is produced by platelets work okay. What we have to do for this bleeding time, this is performed in vivo. We make a small injury. There are several protocols, but usually a small injury that is either in the finger or either in the lobe of the ear. And we measure how long does it take for the body to stop the bleeding. Because usually if we make a small injury, it's enough for this weak platelet clots to stop the bleeding. What we are measuring is mainly the function of the platelets and the function of the primary hemostasia. So we make this small injury, and then we calculate how long does it take for it to stop bleeding. And it's normal usually if it stops before 8 minutes. If it takes more than 8 to 10 minutes, then it seems that something is not working okay with the platelets. Then we have another two tests to see whether the secondary hemostasia, that is the coagulant factors, are working or not working properly. So the ones for both, they are made in vitro. That means that we take a sample of the blood and we put in vitro, and we start putting some substances to see whether it works properly. One of them is to see whether the extrinsic pathway is working properly, and the other one is to see whether the intrinsic pathway is working properly. I mean, if we want to check the extrinsic pathway, then we have what is called the prothrombin time. This prothrombin time will try to measure how long does it take from here, the beginning of the extrinsic pathway, to here, the form of the clot. For this, what we are going to do is, while we are take a sample of the blood, we are going to add in this sample both calcium and phospholipids, because they are necessary for the coagulation, and also we are going to add tissue factor. Okay, we take all those three things together and we put all those things in the sample and see how long does it take to form the clot. Usually it should be between 10 to 14 seconds. If it takes more, it seems that something is not working properly in one of the coagulation factors that is involved in this extrinsic pathway. What we usually do use in clinical practice instead of the prothrombin time is what you may have seen, that is the international normalized ratio. The international normalized ratio is what we do is what we measure the prothrombin time of the patient, and we divide it by the prothrombin time, the normal prothrombin time, and we take the coefficient that should be between 1 and 1.2. Between 1 and 1.2 should be this ratio. If we want to measure the intrinsic pathway, what we usually do is when we take also a blood sample, every time that we take this sample, we remove the cells and we stay just with the plasma, and after that we don't add any tissue factor, and usually apart from calcium, we always needed phospholipids, we add one inert substance. That is why the intrinsic pathway is called the contact pathway, because we don't need tissue factor to start it. It's just with the contact with an inert substance. We can add, for example, kaolin. Kaolin is an inert substance that we are going to add here, so it is enough for it to start this time. That means the activated partial thromboplastin time. So we will choose this when we want to assess whether the intrinsic pathway is working properly. We take the sample, we add these substances, and we see how much does it take to get into a fibrin mesh. The APTT should be between 25 to 35 seconds. If it is above these numbers, then we have a problem in the intrinsic pathway. So to summarize, if we want to see whether our platelets or our primary hemostasis is working properly, we will choose the bleeding time. If we want to check whether our intrinsic pathway is working properly, we will choose the proton-thrombotic time or the INR. And if we want to check whether the intrinsic pathway is working properly, we are going to choose the APTT time. Okay, finally, what we are going to try to do is try to place all the antiplatelets, anticoagulants, and fibrinolytic drugs in this big scheme so that we can understand how all of them works. We are going to start with the antiplatelets. The first antiplatelet will be the aspirin. The aspirin is acetyl salicylic acid. This acetyl salicylic acid really what does is that it inhibits the cyclooxygenase enzyme. So it avoids the production of thromboxane, so it will avoid all the function of thromboxane. We know that it has a vasoconstrictive effect and also have an anti-adhesion and anti-aggregation effect, so it will inhibit all of them. It will inhibit it as in an irreversible form. It means that it will we will need a turnover of the platelets, a renovation of the platelets to get to really get the function again. So it means that when we give aspirin to one patient, we will have to wait between 3 to 7 days to return the proper platelet function. So we have another platelets that acts in this receptor over here, that is the P2Y12. Those are some inhibitors. We have the ticlopidin, we also have clopidogrel, and prasugrel. Those, if we remember, the P2Y12 is a receptor that is activated by the ADP that is released when the platelets are activated, and it really allows the activation of this other receptor that will finally allow the aggregation of the platelet. So those three drugs really block this receptor in an irreversible form. That means we are going to need a turnover of the platelets, a renovation of the platelets to get the function again. So if we give one of those antiplatelet to a patient and we stop it, it will last from 5 to 10 days to get the proper antiplatelet function again. There is another drug that acts in the same receptor, that is ticagrelor, that acts in the same receptor but reversibly. It is not irreversible, it's reversible, the union. So it means that when we stop the drug, we will get again the platelet function in up to 48 hours. So because we don't need new platelets, we don't need a renovation of the platelets, because only when the drug stops function, then we'll get the platelet function again. And finally, there is another one that is called cangrelor. It's also reversible, the union, but we give it intravenously, and we will get the function back of the platelet in 1 to 2 hours. Okay, we have other antiplatelets that will block this GP2B3A receptor. You remember that this was very necessary for the aggregation of the platelets. So we have some of them that block in a reversible way, like eptifibatide and tirofiban. Because they are reversible, in that case it will only take 4 hours to get back the function of the platelets. And we have another one that is apiximab, that blocks in an irreversible way. So in that case we will need between 4 to 6 days again to get the function of the platelet back. So to summarize, with all the platelets, most of the patients that either have we want to cover primary prevention because they have a high cardiovascular risk, or either they have already have a cardiovascular event, it is secondary prevention. In most of them we are going to use aspirin. Most of them we are going to cover this pathway unless there is any contraindication. So when a clot is already formed, then in some cases, for example, if we are in the setting of an acute coronary syndrome, or we have recently placed a stent, or is metal inside inside the body, we want a more powerful antiplatelet function. So in those cases, we are going to add what is a second antiplatelet. We will use aspirin plus one of those. And finally, only in certain very specific situations, usually in the setting of an acute myocardial infarction, we are in the middle of a percutaneous coronary intervention and we have a lot of clot that we cannot get rid of, then in those particular cases, some of them, as a bailout, we are going to use what is called the triple anti-aggregation. We are going to add one of those antiplatelets inhibitors of the 2B3A. And those are the antiplatelets. So we are going to talk now about anticoagulants. You know that the anticoagulants can be used in many different settings. We already know that there are some physiological anticoagulant pathways that try to avoid the formation of a clot, but there are several situations in which we want to enhance these properties. situations, for example, when we have a patient with venous insufficiency or atrial fibrillation, those situations in which because of this low velocity in the blood, then there is an imbalance between the procoagulants and the anticoagulant factors, or maybe we're in the situation where we have already a clot that is formed, for example, in the setting of an acute myocardial infarction, or situations in which, for example, we have an external synthetic material inside the body, for example, a prosthetic valve, in which otherwise could trigger this intrinsic pathway because of the presence of an inert substance in the body. Those are different situations in which we want to have these anticoagulants. Okay, one of the most used are the coumarins. And the first group will be coumarins. It could be warfarin or acinocumarine. Okay, those drugs, really what they do is that they inhibit the activation of vitamin K. Okay, they inhibit the activation of vitamin K. Vitamin K is necessary for the liver to produce some of the coagulant factor. The coagulant factor are factor 2, factor 7, factor 10, and factor 9. So this is the way that coumarin acts. And because this mechanism of action, it has several inconveniences. One of the main ones is that, well, because it do not act properly in the coagulation cascade, it acts before, because it acts in the production of the coagulant factor, it will have a delay on the action. If we act directly in the coagulation cascade, we will have an immediate result. Otherwise, if we act before, then if we stop the production of coagulant factor, we still have the coagulant factor that are inside the body and inside the blood. So we have to wait for them to renovate, to start getting the anticoagulant effect. And that is why if we give a patient warfarin or acinocumarine, it takes some days for him to get the anticoagulant effect. It has another inconvenience, like for example, it has some interaction with food, interaction with other drugs, that makes the function of the drug more unstable during time. So in patients that are with those kind of drugs, we need to monitorize the action. So we know that we have some tests that allow us to monitorize how the cascade is working. So in this case, we will take advantage that one of the factor is factor 7, that we know that this is found in the extrinsic pathway. So it will allow to monitorize patients with coumarins with this prothrombin time. In clinical practice, we don't use prothrombin time, we use instead the INR, that we said that it was the ratio between the prothrombin time of the patient and the normal prothrombin time. It will, remind you that it will take the time from here to here, and when this INR is in between 1 and 1.2, this is the normal ratio. So with coumarins, we are going to try to bring this level up to a level, to a certain level. It depends on the situation. For example, for patients with atrial fibrillation, we will try to put it between 2 and 3. In patients with prosthetic valve, are trying to bring it a little bit higher, 2.5, 3.5, it depends. But the thing is that the point is that we have to monitorize the coumarins with the INR levels. Okay, the next one will be the heparins. We have two types of heparins, and both types are present in the body. Heparins is present in the body in a physiological way, but it is in a very small amount. The heparins, what they do is that they enhance the activity of antithrombin 3 that we have seen that has many anticoagulants effects, mainly in the intrinsic and the combined pathway. So we have two types of heparin, the non-fractionated heparin and the low molecular weight heparin. Both of them enhance the effect of antithrombin 3. But the difference is that the non-fractional heparin is a molecule that is very unstable. It's not predictable. It happens the same as with coumarins. Why? Because this molecule can join to the proteins of the plasma, and it can join also can be attached to the surface of the cells. So it makes that when we give this non-fractional heparin, we don't know the exact effect that we'll have in each patient. And again, we will have to monitorize the effect. In that case, we are not going to use the INR because we don't want to monitorize the extrinsic pathway, because the heparin has the main effect in the intrinsic pathway. We are going to choose the APTT to monitorize our patient. To see that a patient is well treated with non-fractional heparin, we are going to perform this APTT every 4 to 6 hours, and to see whether it's above of 35 seconds to see that it is well anticoagulated. We are not going to have this problem with the low molecular weight heparins, because the low molecular weight heparins are more stable and predictable. So we can give them either subcutaneous or intravenously based on the weight of the patient and the renal function, and we will predict more or less the anticoagulant effect that they will have. So we don't need to monitorize when we give this low molecular weight heparin. Okay, finally, we have another kind of drugs that are the direct anticoagulant, Direct anticoagulants that are relatively new, while they act precisely in different parts of the cascade. Okay, first of all, we have one of them that is dabigatran. We are going to place in here. Dabigatran inhibits this thrombin, this activated factor 2 directly. Okay, and we have another 3 that are called rivaroxaban, also apixaban, and edoxaban. All those 3, what they are going to do is that they are going to inhibit the activated factor 10. This is the way that they perform the anticoagulation. Fortunately, because we are acting directly in the different coagulation factors, then we have a more or less immediate effect. We don't have to wait days, like for example we had with the coumarins, for them to start the effect, because it will be immediately. And then we have another advantages, and is that the effect is predictable, because we don't have other intermediate pathways. It is very predictable, so we can give a dose to a patient. We give the dose based on the age, based on the weight, or in the renal function, and we are going to have a very predictable effect. We don't need to monitorize, we don't need to use any of the times of the test before to monitorize the effect, so they make all of them much more practical. And finally, we are going to see another drugs that what they try is to enhance the thrombolytic or fibrinolytic effect of the in the body. They are used mainly when there is a clot that is already established, for example in the setting of some acute coronary syndromes, only in the ones that we have ST elevated coronary syndrome, that are the one that we have a clot that completely blocks the artery, and also in the setting, for example, of a stroke, or for example in case we have a clot in a prosthetic valve. In some of those situations we are going to use those fibrinolytic agents, only in those, because usually they are they can produce bleeding a lot. Okay, so they act mainly in this point. You will remember that we have the tissue plasminogen activator that turns the plasminogen into plasmin and really breaks the fibrin into the degradation products of the fibrin. What the fibrinolytics do, we have several examples, like for example the streptokinase, the urokinase, the techneplase. We have several fibrinolytics. Or thrombolytics. What they really do is that they mimic the effect of this TPA, and they promote the plasminogen to turn into plasmin, so they start breaking all the clots that they can find. Oh, so that's all with the antiplatelets, anticoagulants, and fibrinolytic drugs.